Good afternoon, ladies and gentlemen. Welcome to the webinar of the European Reference Kidney Network. My name is Elena Levchenko. I'm a pediatric nephrologist from Belgium, and I will moderate this webinar out of my office in Leuven. It's especially nice to have these webinars these days of corona pandemic, which is fortunately calming down in many of the countries. So I'm really happy to see that many people can attend and combine this educational activity with their clinical work or other things you have to do. Our topic of today is genetic causes and genetic testing in end-stage renal disease in adults. And it will be presented by Albertien van Eerde from the Netherlands. Dr. van Eerde is a leader of the nephogenetics group at the University Medical Center Utrecht. She was awarded several prestigious Dutch Kidney Foundation awards and grants, and also received the ERA Stanley Sheldon Young Investigator Award in 2017. She coordinates the Utrecht Center of Expertise for Rare Renal Diseases and is also a chair of the ERKNet Working Group on CACUT and ciliopathies. Currently, Albertien develops their integrative kidney gene network and also the biobank for hereditary kidney diseases. So just some housekeeping rules. As usual, during the webinar, you will be able to send your questions during the question tab on your attendees panel. You can send your question anytime during the presentation, and we will try to answer all of them at the end of the webinar. We will have also some poll questions, so please be attentive. And now I think I can stop my introduction and give a word to Albertien, and we are really very much eager to hear your lecture, Albertien, please.
Thank you, Elena. Thank you for the introduction. Let me start by saying I have nothing to disclose and introducing to you that today I am going to talk about the why, the how, the what, and the when and in whom of genetic testing in adults. I want to stress that this is much too short. The time is much too short to actually go into specific diseases in depth. I'm not going to do that. I like to, I love to, and I love talking about each and every bits of subjects that I'm touching upon today extensively, but time for this webinar doesn't permit. Maybe there will be follow-up webinars. Also, you're very welcome to be in touch if you have any questions. I also want to acknowledge the fact that what I'm going to present very much is based on having extensive testing available in clinical practice, and especially my experience in our ERKNet years and with interactions with our European colleagues makes that I'm very well aware that this extensive testing is in many regions of Europe and beyond. It's not available the way I'm presenting it right now for clinical practice. I didn't adjust my talk to it, but I did adjust the polling questions for it. So I'd like to start with a polling question number 1. What is your field, the field that you work in, just to have a feel? Is it pediatric nephrology, adult nephrology, something else, and more or less than 5 years after your residency? So we have 85% voted. I'm going to close the poll. 88. Let's see, share results. So that's quite an even distribution. I think having at least or 1/3 of people in adult nephrology, that for I think ERKNet will be very happy with that, because usually we have a little less presence of adult nephrologists, so you're very welcome. I couldn't have more than 5 answer bars, otherwise I would be very interested in what the other would be. Let's go to the next polling questions. Next polling question is, I'm opening it right now. Do you have nephrogenetics available in your hospital? And then select one of the following. Yes, I have clinical geneticists and diagnostic laboratory testing. Yes, but only the diagnostic laboratory testing. Yes, but my patients need to go elsewhere for either send samples or for counseling. I can only test through research projects, or I don't have any nephrogenetics available. And I didn't make these questions with a certified bureau, so probably there's options here that I missed, but it's to just have an idea. Yes, so we almost reached the 80% voting. I'm going to close the poll. Here it goes. Share results. So a little less than half have both clinical geneticist and diagnostic laboratory testing available in the hospital. And I think, and this is especially acknowledging, or this is showing what I said just now. If you look at the lowest 2 bars, it's 34%, so about 1/3 of people that can that either have no testing available or can only have patients tested through research projects. I'll hide the results and we'll go to the last. This is about the extent of diagnostic testing you have available. So it's kind of an incrementing scale. You don't have any nephrogenetic diagnostic testing available, and I mean inside your hospital or somewhere in the country where you can send it to. You have access to testing, but only to single gene testing. You have access to testing, and the broadest you can test is gene panels, or the last one is you can only you would be able to have whole exome sequencing if you wanted for diagnostics. And the last one is I can only test through research projects. And again, probably this list is not complete or there's overlap, but you have to forgive me for that. So it's 73, 72% voted, but we're over 1 minute. I'm going to close the poll and share the results. Let's see. So again, this 20% that has doesn't have any testing available. If you add the 4% with that have single gene testing available, that's roughly a quarter of the audience that doesn't have the panels that will be like the main subject of my talk available. So it's important to be aware of this. And I also think in ERKNet, we should this should be on our minds of how we can have people have more access to this kind of tests. 1/3. That's also, I mean, on the other side, 1/3 has access to open whole exome sequencing, exam sequencing. Wow, exome sequencing when necessary. So that's also that is encouraging. I'm going to hide these results. And now go back to my presentation. Yes. So I wanted to start with a case, and it's about a male patient of mine that was referred to the nephrogenetic outpatient clinic in his late 20s. He recently presented because of fatigue. His creatinine was 195. His sediment was bland, and the renal ultrasound showed a normal aspect, size, and position of his kidneys. There were no cysts and there was no hydronephrosis. Before he came to us, he had a renal biopsy and it was revised. It showed extensive IFTA and some secondary focal segmental glomerulosclerosis, and it didn't give any leads for a diagnosis. When I drew the pedigree, and when drawing a pedigree, males are squares and females are circles. Or when asking his family history, it turned out he had an affected brother, and his brother had a renal transplant, or kidney transplant, I should say, at age 19. He also had two sisters that were never tested for anything, but that who were healthy. His parents were had both been in the workup to be a kidney donor, and his mother eventually donated a kidney to his brother. So they were kidney-wise very healthy. And he wanted to know about his children. He wanted to know what his renal disease was causing. Would it be the same as disease as my brother's? And what does it mean for my future children? Or my present and my future children, because they had the wish to conceive more children. In this case, as always, you make a differential diagnosis, but with this kind of presentation, it's difficult as it's very aspecific. But amongst others, you always need to think whether it would be genetic or non-genetic. With this pedigree, genetic is in the top of the differential diagnosis. In genetic diseases, you could think about autosomal dominant tubulointerstitial kidney disease, including MAC1 related disease. I'll get back to that later. It could be nephronophthisis, albeit late. Marijn Stokman had a webinar 2 weeks ago about this. You can look that up. But it could also be other things. So what we did, we performed next generation sequencing of a gene panel of 141 genes involved in young adult renal failure. If you look at the content of that gene panel, you see that roughly, or little less than half, is autosomal dominant, contains autosomal dominant genes or X-linked genes. This would be possible looking at the pedigree if the mother is either a carrier or either patient is a mosaic, because both parents were healthy, remember. And it would mean there would be a high risk for recurrence in his children. The other side of the graph, it's the autosomal recessive genes. Given that he has an affected brother, it's a realistic possibility, although it's relatively late for a recessive disease, not being affected in childhood. But it would mean there is a low risk for recurrence in his children, so it's an important distinction. The caveat there is that if his partner would be consanguineous, which he wasn't, that still the recurrence risk might be higher than you think. So we performed the gene panel sequencing, and there was a genetic diagnosis, but only performing the sequencing would have made us miss it, because he had a homozygous NPHP1 deletion, which is an autosomal recessive disease. It's the main cause of nephronophthisis. And I already said that Marijn gave a very good webinar on this 2 weeks ago, so you can look that up. I'm not going into it in much detail, but suffice it to say that we performed a study where we showed that of patients with adult end-stage kidney disease that are transplanted, 0.5% of them carries these homozygous deletions. And if you tune it to the patients with end-stage kidney disease before age 50, it's nearly 1% prevalence in adult populations. So we're getting to the why. So why do we do these tests? Well, first of all, and it sounds a bit weird, but because we can. So the techniques allow us to do these kind of tests. With next generation sequencing, we can test many genes in many patients. And the past few years have shown, you can see the graph on the left, showing the rise in acknowledged or kidney disease genes. And the last few years have shown that, for instance, in end-stage kidney disease or chronic kidney disease general, the yield of these kinds of tests is about 10 to 40% of patients have a monogenic disease. And it depends, the yield depends on the sample size or the inclusion criteria, very importantly, on the gene selection, the genes that were tested. If you look at inclusion criteria, important factors are positive family history, congenital or cystic disease, unknown origin, or extrarenal features. And the graph on the left comes from the seminal paper by Groupman et al., showing that if you test huge groups of CKD patients, you see that roughly 2/3 are caused by PKD, ADPKD, and COL4A3 to 5 related renal disease. And then there's 1/3 of monogenic causes are caused by other genes. And UMOD is a not rare cause of autosomal dominant tubulointerstitial kidney disease, which was a group of diseases that were also in the differential diagnosis of nephronophthisis. So why also is also about indications, and there you can have a lot of distinctions or categories, but I think a very helpful frame of mind is the difference between doing genetic testing for establishing a diagnosis or doing genetic testing even if you have a clinical diagnosis, but you may need it for other things. And I'll go through both arguments with you. So first, establishing a diagnosis, an accurate diagnosis is, you'd like to have that in cases where you don't know what the cause is or you don't have clues. Also, for instance, in end-stage renal disease, or for instance, in disease entities that are much more descriptive than etiological. Also very much so in patients with atypical features of typical disease. ADPKD is the best example. For instance, a patient with typical ADPKD but a negative family history might have a de novo ADPKD, but might also have a phenocopy like ARPKD presenting late. So those kind of clues, segregation or pedigree doesn't fit with the diagnosis, or it's too severe, too young. Those kind of things they should make you aware. It's also important that all these large sequencing studies are showing that performing genetic testing also reclassifies a significant subset of clinical diagnosis. So even if you think your clinical diagnosis is right, it's good to bear in mind that a subset of these are reclassified by genetic testing. Well, why do you want to establish a diagnosis? To have more, to be more sure about prognosis, to know what kind of treatment and follow-up to have installed for the patients. For instance, if you know a specific gene also involves extrarenal features, so you know you can follow those up. You can follow those up. And for instance, treatment-wise, also important to know what treatments you don't have to give, like steroids in genetic FSGS or genetic nephrotic syndromes. Don't forget that even for patients where there's no intervention or treatment or whatever involved, the answer as to the why of the disease can be very important. for coping. You can prevent other diagnostic tests. You can really make the diagnostic odyssey smaller, especially if you had like it's starting to happen, especially already in pediatric nephrology, but also in adult nephrology, if you take a genetics first approach. And establishing a diagnosis, also a clinical diagnosis of a genetic disease, is important for genetic counseling. For instance, in informing patients about the risks for their siblings and their children. So then we go to the right. Even if you have a workable clinical diagnosis, for instance, typical ADPKD with a fitting family fitting pedigree, even also some people with liver cysts, and everybody has typical enlarged kidneys, and end-stage renal disease is somewhere between 55 and 60. So really typical. You need a molecular diagnosis for tailored treatment. Maybe ADPKD is not the best example, but also an ADPKD, for instance, having a PKD1 truncating mutation does give has some points in the tolvaptan treating algorithm, but also in other diseases where we are starting with N-of-1 trials, proof of principle trials in organoids, then you really need to know what the specific mutation for the patient is. And again, so that's why there's a 2. This is important for genetic counseling, because having a molecular diagnosis increases the options for family planning for patients that would be inclined to go for prenatal diagnostics or for embryo selection. You really need to know the pathogenic variant. Also, a molecular diagnosis can be helpful for definite disease exclusion for family members at risk. For instance, if patients are still too young to know for sure that clinical testing is makes a definite disease exclusion, like ultrasound in a ADPKD patient of 20 years, especially when it's about living related donation, or maybe there's ambiguous ultrasound results, then it can be very helpful to have the pathogenic variant in the family, and know that you can also do DNA testing in family members. Why do you also need these molecular diagnoses? But that's not a patient argument, but it's a doctor argument. It's to identify the outliers, to identify the special cases, to identify the unknowns. And I'm saying it's not a patient argument, but in real life, of course it is, because you want to know, it's good for patient care to know what the outliers and the special cases are, in order to tailor their treatment better, and in order to find their diagnosis. That's also why there's an arrow, and these 2 columns, this left and this right column, they are not super distinct. There's crosstalk between the 2 of them, and especially with regards to reclassification, there are many examples of patients where the clinical diagnosis seemed straightforward, and then the genetic testing revealed that it was much different. So now to the how and the what. I'd like to compare our DNA to a library of recipe books. In that comparison, one recipe book is a gene. It's important to know that the exome, the definition of an exome is all 20,000 of all 20,000 genes. It's also important to know that of these 20,000 genes, roughly 6,000 the function is known. That means that for 14,000, so 2/3, the function is unknown. And this means that a genetic test with a negative result can never rule out that a disease in a specific family is genetic. In other words, you can prove that a disease is genetic, but you cannot disprove that it's genetic. Also important to know is that these 20,000 recipe books, they're still only 1 to 2% of the genome. So as closely packed as they seem in this picture, that's not there's much DNA in between, let's say. So what types of variation are there? On the left, you see the single nucleotide variation, so base pair changes. And depending on the position of the base pair change, it can range from a neutral variant, a single nucleotide polymorphism that can be assessed for GWAS studies, but in itself doesn't do harm, to pathogenic variants. Beata, in her webinar 6 weeks ago, I think, she already gave an introduction on the genetic idiom, so you can refer back to that. On the right, you see copy number changes, so pieces of DNA missing, maybe small pieces, bits of genes, whole genes, or even series of genes missing or duplicated. And then on the downside of the slide, you see that there's many other types of variation that I'm not even going to go into, but that you can bear in mind if you have negative testing results, that there's also other possibilities for to have genomic variation. So how about these tests? So we have single gene tests, and usually we do them if you think there's really in your differential diagnosis, there's a classical phenotype with a single causing gene or maybe 2 single causing genes. Then a single gene testing is the way to go. Then one step below, in the middle on the right, is the multi-gene panel test. We use them a lot, especially in cases where there's multiple causing genes, or the phenotype is quite atypical, so you're not sure in which phenotype category the patient is falling. For instance, again, in patients presenting with end-stage renal disease, kidney disease, I should say. And the test in the lower right corner is whole exome sequencing, meaning reading all the coding regions of the DNA and assessing the whole exome is something we do if there's an uncertain phenotype or unknown causing gene. We prefer to do that in a trio setup, so also with the parents of the patients when available. And why did I draw the blue line? It's because nowadays, at least in our lab, the preferred way is to actually perform the whole exome sequencing, but then have the computer filter the panel from that, meaning that you only get the panel result, but later if you want to run another panel or open up data or check another gene, you can use the data that's already in the computer, which makes it very flexible. I'm not going to explain in detail what next generation sequencing is, but I'd like to show you these graphs. On the top left, you see a visual representation of a bit of DNA. And the sequencer will actually read short bits of this DNA. And you actually call them reads. And then these reads are also read by the sequencer. And these bits and pieces of DNA are then, through computer algorithms, mapped back to the reference genome. And if in one of these pieces there is a mutation, it will be mapped back so you can see where it is in the reference genome. Why am I saying this? Because this can also go wrong. You see the blue bit of DNA pulsing in the middle right. This is the way some regions can look, and we call that there's repeats. For instance, variable number tandem repeats. So then there's a large area of repeated DNA, And you can imagine that the sequencer can read the DNA, it can generate the reads, but the computer will have a very hard time mapping back where these bits and pieces fit to the reference genome. And why am I telling this? Is because one of the probably very prevalent end-stage kidney diseases, monogenic end-stage kidney diseases in adults. I showed it on the top, the title. It's MUC1-related autosomal dominant tubulointerstitial kidney disease, is actually in one of these regions. And this is why it was so hard to find where it is. And this is also why you don't, why you cannot make this diagnosis with regular next-generation sequencing. So it's important to bear in mind. Also, talking about these CNVs, so copy number variants, deletions, and duplications. If you have whole genome sequencing data, it's relatively straightforward to assess copy number variants from that. VES data, so whole exome sequencing data, it's possible. It's not so straightforward, and there are some drawbacks. And in diagnostic practice, still, if you want to assess deletions and duplications, usually SNP array or array CGH is performed if you want to do it genome-wide. And if you have a suspicion for a particular gene or really want to know if each and every part of that coding bit of gene is there, we use MLPA, which I'm not going to go into, but that you can look that up. Click. So it's important to know, like for MUC1, that MUC1 you don't find with regular genetic panel testing, but there's also two genes that are in fragile regions that can easily break, meaning that there's whole gene deletions that are often a cause of renal disease. I already mentioned MPHP1 for nephronophthisis in autosomal recessive fashion, so you need homozygous deletions or one deletion and a mutation on the other allele. Also HNF1 beta for again for ADTKD HNF1 beta. That's an autosomal dominant disease, so you only need one deletion to have the disease. And it's important to realize that the normal sequencing normal result of next generation sequencing panel will not tell you whether this was assessed, and only if the result explicitly says they looked at it, you can count on that they performed the algorithms for the CNV analysis. I showed you the graph before, but I didn't tell you that in the gray clouds above the steep rise in discovered genes, it's actually a visual representation of expanding phenotypes. One example is that when we discovered COL4A5 for Alport syndrome, nobody knew that only a few years ago it was discovered that COL4A3 to 5 mutations are also detected in patients that have FSGS on biopsy. This is only one example. I gave an update on expanding phenotypes in the lecture for the ERA EDTA. It's still online, you can look it up, and I'm not going to go into it in detail, but I did list for people wanting to look it up later, the papers that I used for that. So don't read them, but the slides will be available for later. Well, you have to read them, but not now, I should say. One picture to just spark your interest in how phenotypes can be different. They can be different for lots of reasons, but it's also important to know what kind of mutation is there, because that can definitely have an effect on the phenotype and the severity of the phenotype, also location within the protein. And there's lots of other ways where phenotypic heterogeneity can be, lots of other ways that can cause phenotypic heterogeneity. What does this mean in daily practice? Well, it means that thorough phenotyping and genotyping in large cohorts is essential to find expanding phenotypes. And for instance, the ERKNet registry, ERKReg, is on its way to help for that, but there's also a lot of other cohorts and biobanks out there. Also, Beata already alluded to that. Multidisciplinary settings are important to attribute causality to variants, both in patient care and in research. And it's important to realize that when you perform gene panel diagnostics, it's important not to make the panels too narrow. And also that I really think, and we're already seeing that establishing a very accurate phenotype before testing might be outperformed by genetics first approach, and then do reverse phenotyping after that. So in whom, and I already mentioned this a bit in the types of indications you have, but you can also look at this from this way. You can see the phenotype as an indication. For instance, there's a typical clinical presentation where the differential diagnosis of a genetic disease is in the top. But also atypical presentations, and in general, this would be too young, too severe, end-stage kidney disease under 50, ADPKD, but doesn't quite fit, those kind of features. A positive family history, and at least until the second degree relationship. Extrarenal features should spark awareness. Atypical, oh, that's double, oh well. And unexplained renal disease. That's definitely an indication for genetic testing. Then tuning treatment or interventions for individual patients is an indication. For instance, I already mentioned steroid-resistant nephrotic syndrome and FSGS in case of steroids, but also complement-related disorders, and also the potential of avoiding other diagnostic tests. And the indication could be family-related. So, for instance, in living-related donation, counseling family members, and family planning. And I already said, but it's important, so I'll repeat it, that if people are interested and it's available in prenatal diagnostic testing or embryo selection, then you really need to know the pathogenic variant. It's also important to realize that patient situations change over time. So you need to make sure you're up to date. This means revising the primary renal disease diagnosis, maybe yearly, preferably in a multidisciplinary setup. And if you don't have that available, ERKNet also provides expert consultation. You need to revise the family history, because obviously family histories change. Babies are born, siblings go to doctors that were previously healthy, etc. You also need to check regularly whether patients' preferences with regard to family planning have changed, especially in the reproductive age in case of living-related transplantation and when there are new treatment options. And word of care in case of patients with no or a few symptoms, but maybe a positive family history, then there might be insurance implications. And one of the things we always try to do is then try to test an older or more affected person in the family that will have less insurance issues. And at least in the Netherlands, for pre-symptomatic DNA testing, so there's a disease in the family and there's a healthy person in front of you and wants the DNA test, that can only be performed by the clinical geneticist. But I'm aware that this is different throughout Europe. Shared decision-making is essential, not only, but especially with regard to reproductive options for adult onset renal disease. In 2015, the KDIGO ADPKD Controversies Conference already stated that decisions around pre-implantation genetic testing are for the patients and or parents to make and should be included in the discussion. Although the availability of financial coverage vary, but this really states that we should take these or inform our patients and make decisions together. And I think in countries with genetic services available, you don't have to do the whole conversation yourself as a nephrologist, but you can refer to the genetic center for that. But you as a nephrologist need to find out whether your patient might be interested. So take home, a significant subset of adult onset, I would say age roughly under 50, end-stage kidney disease patients will have monogenic disease. Take home that patients go through life like all of us, so lives change, families change, and take that into account. Take home that gene panel diagnostics is great, but there are at least 3 relatively frequent causes of monogenic adult end-stage kidney disease that will not be detected with the standard method, and I mentioned them throughout the talk. Thinking about which patients to test, my advice would be, if you have the opportunity, be a bit liberal, and also as for panel content, be a bit liberal. Establishing a very accurate phenotype before testing might be outperformed by a genetics first approach, and is already doing that in subsets of disease groups. A negative result does not mean a disease is not genetic, and multidisciplinarity and shared decision making are essential, I think, in bringing this field forward. With that, I'd like to thank my colleagues in the Expert Center and my collaborators, also the Nierpatiëntenvereniging Nederland, so the Dutch Kidney Patient Organization and the Dutch Kidney Foundation, the colleagues at ERKNet, and in the ERA-EDTA working group on inherited kidney disorders. These are the next webinars that you're very much invited to. And you can contact me on the email address that's above. And for that, with that, I'd like to go back to Elena.
Thank you very much, Albertien, for a very comprehensive, also very practical presentation. So while people are thinking about the questions, so please write your questions in your question panel. Maybe I can start with the first question. I think when I listened to your presentation, I would say that more or less all patients with kidney disease, also when they're adults, need to be tested. Can you maybe say also on the practical term, do we have patients that don't need genetic testing? Because
well, if you understood that I'm saying everybody should be tested, then I should probably rephrase, because what I mean is that we should be aware of the potential that there may be a monogenic disease going on. Still, for instance, well, there are hereditary kidney cancers, but if people lost kidneys because of, or kidney renal function because of HIVAN or diabetic nephropathy and the renal failure, and it wasn't well controlled, there's definitely autoimmune, there's definitely reasons why genetic disease is not in the top of the differential diagnosis. But my main point is that we should be aware of the possibility, and then the choice whether to do something with that depends on the availability of the testing, of the need of the patient, of is the patient in a reproductive age, would the patient consider prenatal testing or pre-implantation pre-implantation genetic diagnostics at all? I mean, these are all kinds of things that may that you have to weigh when deciding whether or not to pursue the testing. But my main point is that we should be aware of the possibility.
Okay, thank you very much. Yeah, I think very obvious diseases, like very frequent diseases in adults, like diabetic nephropathy or hypertensive nephrosclerosis might be here. Although I think also there you can have genetic causes there, but
I'm
yeah.
sure, and I think especially hypertensive. For instance, we have had patients where with end-stage kidney disease at age 30, and then it was attributed to hypertension. And I tend to then think, well, maybe, but also maybe not, and be critical. If it's too young, too severe, then I think these days the literature supports, if you have it available, to do genetic testing.
Yeah, sure. I think we have several adult nephrologists in the audience, so I think please, if you have questions to Albertine, ask them. I have another question, Albertine. So we have seen that about 1/4 of our audience are living in the countries where wide genetic testing is not available. What do you recommend for those people, except that they can maybe contact you and discuss, but which approach do you recommend? Some limited testing or no testing, or just, I don't know, contacting somewhere outside of the country?
Yeah, so given that as a practicing clinician, I don't have to deal with that situation. I'm not super experienced in that, but I know from colleagues elsewhere that through ERKNet or other kind of disease registries, it's sometimes possible to like send in batches of samples for research testing. And we should always be aware that in research testing, sample mix-up are easier, and all kinds of those kind of things. But still, it's probably better than not having testing. Also, I think I tried to give guidelines is to they weren't guidelines, but give some rules of thumb for which patients it might be important. So you can also try to think for which patients or which families would it maybe make a difference. And you can also think the other way around, because not having the testing doesn't mean that you shouldn't have it in your differential diagnosis and maybe act upon it. So even if you don't have the testing, but you think there might be a genetic disease going on, you might advise the siblings or maybe the children to have blood pressure and proteinuria screening, which usually is not too expensive and available. So even if there's if you don't have the testing, still having a genetic disease in your differential diagnosis, I think, is important. Can be important for a clinical practice.
I agree. In the meantime, we have a question from Dr. Viola D'Ambrosio. She asks, what would you say are the long-term outcomes of genetic testing in adults affected by end-stage renal disease? I think maybe what are the long-term consequences of genetic testing in these adults? I think you covered it a little bit in your lecture, but maybe you can stress it or repeat it. Huh?
Yeah. So as for consequences of the patient him or herself, especially when it's end-stage kidney disease, let's say somewhere above 35, then you might still find indication of mild extrarenal features that you can have that you can have checked or followed up. Admittedly, if the patient turned 35 without having being bothered by extrarenal features, then likely the patient, him or herself, won't be bothered that much in the years after. But it can be very helpful for family members. For instance, for children that want to conceive, it can be helpful for knowing who to screen, who not to screen, family members that want to know whether they are actually affected or not. Also, even if the patient, him or herself, doesn't have any more treatment options available because it's already end stage, still maybe, for instance, the COL4A3-5 related disease, we know that ACE inhibition will really likely help. So then you can advise that for family members, those kind of things.
Yeah, I agree. I think
I hope that's
for patient, yeah, I think I agree with you. I think for patient itself, for the kidneys, obviously when you reach end-stage kidney disease, your genetic diagnosis will not influence your direct treatment. However, for the extrarenal manifestations, it might be very important. Another example might be finding HNF1 beta mutation, even if you don't have it at the moment of the presentation, those patients might develop diabetes, for example, later in life or after transplantation, which can influence your immunosuppressive regimen or the screening policy. So I think for the extrarenal manifestations and obviously for the counseling of the families. So we have now another question.
And I'd like to add maybe that, for instance, the hereditary FSGSs, we know that they don't recur in grafts. So exactly. Although, so that's important. And also in the complement disorders, there are some disorders where knowing the genotype will make having eculizumab ready by the time of the transplant or not. It does inform the post-transplant course or treatment.
Absolutely, absolutely. The post-transplant or peri-transplant treatment can also be very different. Yeah. So we have another question from Dr. Natasha Stachik. He's asking, is it advisable to perform microarrays or MLPE in patients in whom deletion of the whole gene is possible, or we can expect this to be found by the geneticist who performs kidney genetic panel testing? And she thanks you for the great presentation.
Thank you, Natasha. It's very nice to hear that you listened. It really depends a bit on the situation in the country. So in where I work, the treating doctor, whether it's a nephrologist or the geneticist, needs to kind of know what kind of tests are there and what kind of tests what the test can do, and so you need to request the testing. I know, for instance, in France, and people, please correct me if I'm wrong, but the way I was told, you just write down the indication and then the laboratory specialist decides what test is performed. So that's really a difference. Do I think that we need microarray or MLPA in patients where panel testing has been performed? Well, if you know that your lab does use algorithms to get CNVs out of the no, I need to start again. If the gene panels are taken from VES data, so from whole exome data, if you know that, then we know that pretty reliable SNP array-like, we can also call CNVs, so deletions from that data. But that needs to be specified in your panel result. Otherwise, you cannot be sure that they did that. It's an extra calculation they need to do, or an extra analysis, I should say. If the panel was made from a smaller enrichment, so not from whole exome sequencing data, but from a selected set of genes, then you cannot reliably call them. The other way around, reliably calling, I think it's about 3 exons in a row, so like let's say 3 chapters in one of those recipe books. If you want to go smaller, if you, for instance, have your differential diagnosis is 1 gene and you really think it needs to be 1 gene, this particular 1 gene, then you need an MLPA, because MLPAs are really designed to go chapter by chapter to see whether there might be 1 small deletion. I hope this answers your question.
Thank you very much, Albertine. I see that we don't have any other questions, and our time is also running out, so I would like to thank you very much for your excellent presentation, and I also would like to thank our audience for being here with us today, for listening, for asking questions, and once again, all of you are very much welcome to attend our last webinar of IPNA this week, and we will restart with our webinars in September again. And I wish you all very good summer holidays, and please stay safe. Thank you very much. The webinar is closed.